Welcome to the Health Tech Crew podcast, where we delve into the intersection of technology and healthcare innovation. I'm Igor Gorlatov, partner at Kepler Team, and today we're joined by Debra Graham, Vice President of Clinical Informatics and Physician Services Group of Florida. With over 25 years of experience in acute hospital, clinical, and healthcare information technology, Debra's expertise spans clinical transformation, medication management, EMR, interoperability, and telemedicine. Her strategic thinking and commitments to improving efficiency and patient care make her a leader in the field. Let's explore her journey and insights into the ever-evolving world of healthcare technology. Hello, Debra. Thank you so much for agreeing to talk to me today.
You are very welcome.
Before we started recording, you mentioned that you are in a hotel. Could you tell a little bit where you are, like where are you located? What's going on?
Sure. I live in East Tennessee. And in fact, this is I am all vol. I'm a very proud Tennessean. I almost always have my water bottle. People sometimes steal it. And then I wear my Tennessee state, but I work in Florida. And so this morning I left the house at 4:30 a.m. Central, drove to Nashville, flew to Pensacola, where our home office is. And then I have a meeting in Tallahassee this evening. So our business physician services group of Florida is, we started with 4, I think, facilities in Pensacola, 2020, right before. I think I was hired March 3rd or 10th before the world shut down later that March. And then at the end of this month, we will have 25 facilities between Pensacola to Tallahassee down into Stark, Perry, Florida. So we've had quite a bit of expansion, and I travel around to those places.
Congratulations on this growth. So I know your role is VP of Clinical Informatics. Could you talk a little bit what is included into your primary role? And other than travel, what does your typical day look like?
All things integration, access to the multiple systems. A huge part of what I do is I'm an advocate for our telehealth services, which we partner with someone for that. But a large part of what I do is work with the facility. So we, physician services, have privileges in these long-term, they're skilled nursing, a couple assisted livings, and then some long-term nursing homes. So we're not employees per se of those facilities. We are guests, and our two owners like to say, and not being trite, truly, that we serve at the pleasure of the facility. And so very much a customer service advocate, a process person to deliver the telehealth, to introduce that to the leadership, to get their buy-in, to do a lot of the introduction. And I like to be at the elbow of the staff nurses. So these are the staff nurses of the facility, evenings, nights, weekends, to promote the use of our telehealth. This was actually my doctorate project as well. So my doctorate work was done in evidence-based practice and bringing that telehealth intervention to long-term care to reduce readmission. So integration, staff education of our own folks to our systems that are integrated into other people's systems, a lot of troubleshooting, a little bit of operations and all of that, a whole lot of customer service. And then I'm also do a lot of the reporting. So the data analysis and reporting to our facilities on our services, and most of it all comes back to readmission rates and our impact on that.
So you shared a lot. I wanted to unpack this a little bit. So in terms of specifically your day, could you pull your calendar and tell me what exactly is in your schedule for tomorrow? You don't have to say specific names, but what are the meetings or what are the time blocks that you have planned for tomorrow? If there is
sure.
I can be.
Tomorrow, I will still be in Tallahassee. And so I am going to see the administrator of one of our facilities because we started our telehealth implementation, but we had a roadblock with integration. And so within their own systems. So we didn't get to go live. And so I hope to get to go live Monday. So the morning's going to be spent pretty much in following up with those people. And then in the afternoon, meeting at one of our other facilities with that administrator, director of nursing. And then within that facility, employees of ours is a nurse practitioner, and the medical assistant is pretty new. So I just want to follow up on some things. We audit their performance and metrics. And so I just want to review that and some processes and just, be that. Being remote is fabulous. I've worked remote for 13, 14 years now, but I don't think there's anything that replaces the face-to-face. So I just want to see them. And then I will drive back to Pensacola.
Oh, very cool. Thank you for providing this specific kind of tangible things about what you actually do. This is very helpful. I also wanted to ask about PSG, like about your business model. I've chatted a little bit with ChatGPT, and it provided me with some examples of similar organizations, like Envision Health, I think was the one of the biggest. So what is, like, I understand it's a physician group, and you mentioned that you serve like long-term care and nursing facilities. But how does the model operate? How do you make money? And what's your value proposition to your clients?
We make money by billing Medicare, skilled A, and then and then any Part B on the long-term folks. That's how we make our money. The facility doesn't pay us at all. The facility's not paying us to be there. So that's how we make our money, knowing that the skilled facilities are going to impact our bottom line much more than the long-term Medicaid only ones, but we serve them all. And sometimes in our business model, some of the larger organizations are, before we let you on our skilled, we'll go send you to a longer term, less turnover facility. Our value add is that traditionally it's very difficult for long-term care to be in compliance with Medicare and conditions of participation because of a physician seeing them, say, in long-term care every 90 days. So our model is that we place nurse practitioners. We are getting a PA soon, but for the most part, it's always nurse practitioners that they are in the facility Monday through Friday, 8 to 4. So it's not just somebody comes by for an hour every 3 days. And so that's our value add. And also we're helping them be compliant. We are fully integrated into their EMR. So our notes appear quickly. So again, if an auditor comes, so it is good for compliance. We are providing the telehealth service that doesn't cost the facility. And all of that to try and increase satisfaction, reduce readmission, and help them meet their metrics in their treatment of those patients. Some of them are, in ACOs, some are looking to, so it's, some of it is we want them to stay as a short stay. Other models are, so balancing that, the billing, the changes in billing.
But this is awesome. Again, you gave a very concise and exact explanation of what exactly your business model is. At least it resonated. I understood much better than from ChatGPT. And I also know that you have some teaching engagements. So could you talk a little bit, how do you balance demands of the current role with teaching?
After I finished my doctorate in nursing, just last year, it's just been over a year now. So the University of Texas at Tyler offered me an opportunity to teach. I just teach one course. It's healthcare informatics in the 21st century. It's a requirement of masters in nursing that are seeking a certificate. So it's a postmaster's certificate in nursing informatics, quality, and safety. And last night, I had a class. It's all remote, and it's not independent study, but it's pretty much they do their work per the syllabus in 15-week semesters. And I love getting to meet them. It's not a huge time commitment for me, Igor. I wouldn't take any more. I couldn't take another class. I'm behind in grading right now. Everyone that teaches in that program works, is employed in the industry. So I think that's important to the program. I love meeting the students and what they're doing, what they're pursuing, what their backgrounds are. Last night I was in an interview. I invited a colleague. I don't know, I've known him 6 or 8 years. He is now a high-ranking nursing informaticist in Mayo. And so we brought him in, and the students just asked him questions about how did you get there? What are your leadership skills? What do you look for in a resume? That kind of thing. And I think it just keeps me in tune with what's happening out there.
Are you gleaning some insights that you can use either in your teaching from your work or from your work in your teaching? Could you give some examples of those?
Well, something you mentioned that I have gleaned in my work, in my teaching, and my getting ready to submit again is ChatGPT. I am just loving. Last night in that discussion, this is an enterprise person throughout all of Mayo, any system that it affects everyone, every physician, user, etc. So he was talking about using machine learning, ChatGPT, however you want to say, natural language processing, sort of all combined, to look at that record, the electronic records, and produce that care plan. Care planning historically for nursing is just such a fluff paperwork. It's just, no one loves it that I know. So to use what you've done and let the system populate that care plan from that, to even in our system that we use at Physician Services, it's not ChatGPT, it's not, but there is a compilation at the end of their documentation that produces PDF that they electronically sign. So it's, you're just not having to say every word or put that in sentence format. And then the last part was the man from Mayo mentioning that to even produce a summary note from your nursing care at the end of a shift, how much time that would save. For me, I just love it to put in some thoughts of like looking at this workshop that I'm submitting for next year, just put in some thoughts and skills and say, write 4 objectives. I put in 4 or 5 of us, I have a significant birthday come November. And so I just put in some, things about 4 friends, give me, some titles, some, potential, whatever. Out it comes. I think it is fascinating. And I've also had some discussions with my leader at the University of Texas. I guess there were the same sort of concerns with, the good old internet, probably with the word processor. Like when I was in school, I graduated nursing in 87. We had some professors that said you couldn't use a word processor. Wow. What did it matter if I typed it or let the word processor do it? So I find it like it is obviously you can't print that out and put my name on it, but I really like the generation of the ideas, the verbs it uses, just the, and there's lots of tools out there. So those are some examples.
So just to continue on this, it looks like you're super excited about ChatGPT and its potential, especially in terms of time savings and producing like patient stories. Are there any tangible plans for PSG to implement some of that technology or pilot some of the things?
No. No, sorry, don't have any.
And why do you think it's like difficult for organizations like yours to experiment with the new word processor, so to speak?
Well, for one thing, within the nurse practitioner and the physician workflow, into the electronic record we use is GeriMed. It's kind of campy, I think. GEHRI Med, owned by NetSmart. So this is one part that really may need edited. But so even with professionals, even with people that have their expertise, I have a physician that she does great with the patient. She is fabulous at the bedside. God help her remember a password. And so I think for them to, I've mentioned to you, we changed from Office 365 to Google Suites this year. And even that, when that is not what you are accustomed to, or to change that. So I see it as, if the system itself could do it, maybe, but for our nurse practitioner to go out there and use ChatGPT to do something, I mean, I've shared that with our CMO. He's all about those kinds of things. So maybe you've inspired me to talk to him about how we could do that. I have also done some things about performance improvement, issues with continued, whatever. I mean, it's talked to her 3 times, had a performance improvement plan, give me a performance improvement plan based on blah. I think it's just really good tools. Sometimes it's too, not me.
So I think we are talking about a curious thing. So we have an innovation with obvious benefits and obvious opportunity for cost savings, but there are certain barriers within the healthcare industry or long-term care industry, or just a specific organization and how people operate to adopt those innovations. And this is not uncommon. Do you see areas where innovation is most likely to get adopted, and specifically in long-term care? Like when we talked before, I think you highlighted opportunities in terms of multidisciplinary partnerships through telehealth, using remote supervising, nursing liaisons.
Yes, good thoughts. And any of that. So you always stretch me, Igor. So into the silos. So I'm in GeriMed, they are in something else, and then telehealth. And then most of our facilities are in point click. So if there was some umbrella of machine learning, of data mining to pull that together, or because we're having challenges and we're addressing way back to communication. Just, I don't know if you've heard, years ago, Joint Commission and hospitals got really big. Well, they should be, but there was a huge highlight to hand off communication from department to department. And we even literally had these, almost like grocery checklists, like a skinny piece of paper that we called the ticket to ride. A lot of people had that. That's what they called it. And so even that, if we had something that would look at the day's care of the lab, and the telehealth does some sort of a, like a, not crisis management, but like a risk assessment. So to look at those and communicate that, to hand off to our telehealth partner of, take a look at these or be aware of that. And this is happening now at Mayo. This isn't, this was shared by Will Watts that I met with last night, that already within their systems, if a lab is normal, systems are evaluating that. It's been tested and it's in practice in some places, that they get reordered or continued really without any human touch. So those kinds of things are fascinating to me. But you've inspired me over to a future assessment of how the day's notes could be evaluated, and give me the top 5 concerns that I could pass off to them. Because now that's an issue. It's an issue for us as caregivers to come to the end of the day to actually type in what we might think might go wrong that evening.
And I think like this specific use case, it's pretty straightforward. So it doesn't require, I know like organizations like Epic and Microsoft are partnering to properly integrate
Yes.
ChatGPT with all the compliance in place. But
Mhm.
having like this use case that you mentioned, it's not a huge undertaking if you wanted to pilot something and try and get value from innovation quickly.
Mhm.
Something
Mhm.
definitely, I'm curious what your thinking is going to be as you like take this further.
Well, thank you for asking the question. You've got me, I'm just using as it is and not even consider. It's embarrassing that I hadn't even thought about it.
I don't think that's embarrassing, and that shows that you're curious, you're open, and this is what I'm trying to get in those conversations. So it's not like we talk only about things that we know. That's boring. It's exciting to talk about things we are thinking about or we're curious about. And I'm really curious because I don't know much, even like in comparison to a typical practitioner. Healthcare is a maze for me, and I'm kind of shining light at different pieces and trying to understand them. So we've talked a little bit about AI. We've talked a little bit about optimizing certain pieces of the work. Are there any other developments specifically in long-term care or in healthcare industry in general that you are most excited about?
Long-term care, I could get excited. This sounds, it's a little boring, I guess, but I long for long-term care to just get to the present state of acute care. So far behind, still so many medication errors. That would be another fabulous place for artificial intelligence to look at those medications. We are still so heavy in paper in the industry. So many, many opportunities for innovation, and there's just not those incentives from payers to spend that money as our reimbursement gets smaller and smaller. So with those cuts, so that's just really difficult. So we have to look for ways to use the technology that we have to lessen the burden on our caregivers. Just for example, when I started the whole telehealth stuff, implementation, I shouldn't say stuff, that wasn't perfect, the intervention and bringing that into the system. I, for 4 or 5 weeks, Igor was and it never come to Pensacola yet. This was in the midst of COVID. And so yeah, we were using iPads to get in and out of rooms and not be exposing, but we weren't really using it in its true sense of offsite provider and using it to intervene quickly. So when we started that as our handoff communication and after hours coverage, 4 or 5 weeks, I went at the implementation plan with the director of nursing, a corporation level person within those facilities, the telehealth provider, a project manager within the telehealth, our CMO, all these people, meaning that we put some planning into this. I mean, it was not like 2 of us decided to do it. Corporate input from all 3 organizations that were partnering together. And it was the 5th or 6th week when I realized the staff nurses in the facilities didn't have email.
Oh.
And so the vendor was, we deploy this, we send them this, they can reset their username, password, etc. Well, what? they what? And this is very common. I serve on the board of a continuing care retirement community in Tennessee. Their staff people don't have email. I mean, it's still so I could get excited about increasing the interoperability and the communication between. Still, you send somebody out in a ambulance to the facility, to a hospital, to an acute care, and they can't find the paperwork because it got sent. So I could get really excited about that. In the industry, what I think is really cool is looking at what will replace this nursing staff. Will we use more technology to have not telehealth to a physician, or not a licensed provider, but just to that nurse that could like things, you have to have two things. Like I have to have two licensed people to witness this drug or, look at this syringe. I need, the same with the IV pump. So using extenders of licensed people to help you with that. What's going to happen with the baby boomers and, a new nurse, I think it's like 57% of the new RNs only stay in acute care 2 years. So we're just not going, not going to have people to do that. So what can we do in the meantime to promote that, to entice, to look at these staffing ratios? So the more so, I guess, the business side, the strategic replacement from that, and then, the nursing faculty as well. I'm all over the place, Igor. Sorry.
Let me kind of zoom in on one aspect, and it might be a radical aspect. Or one of the previous guests I had was Dr. Joel Solonikio, and he used to work for CDC, and part of that, he traveled to different parts of the world where medicine is not available, where it's not about replacing a doctor. There is no doctor, there is no nurse, and this is the majority of population. And his firm belief that it's not like augmenting doctors that the AI or the next iteration of ChatGPT will do, but it will be the doctor for the vast majority of the population in the world. It will be the way to get care, to get medical advice, and to get treatment. What's your take on this radical idea?
Well, I think it kind of reminds me of, years and years ago when it was, how are we going to get wireless capability or broadband to Africa? Or, then we don't. We just get everybody a cell phone. So we just, forget the computer and the wireless setup. It's just not going to happen. So part of me is like, yeah, that's fabulous. And then there's the other part that is, how scary is that? I worked for the only time I really know that I saved someone's life. I was an intensive care nurse, so I hope I kept a few people alive for a while, but I had to work. I shouldn't say had. I chose to work one summer as a young mom, and I worked for the county in the school system. And so I would work at the jail as well. And so, but this man came in and they were, like a deputy person was setting the medications up based on what was on the bottle. They would have killed him with what it said on the bottle. So I don't know if that was a pharmacy error, a doctor error. And I called our physician that, like on a Sunday morning, and, was like, this was, if he would have continued to taken that, he would have certainly died in jail. So then it's that kind of thing. But I guess if that's all you have, or, you hear about the surgeons that are videoing, in these third world countries and just doing their best, or this hospital at home stuff. I just wonder how. I think there's some great positives to it. I just have a lot of questions about how that all works out in the end when something goes wrong.
Sure.
In our litigious society.
For sure. But I like your example of cell phones versus like broadband. And it looks like it's hard to, like, you can get evolution to a certain point of a system, but once the system becomes so huge and bulky and unwilling to change, you need something like that leapfrogs over that system. And I don't know, I'm just curious if this is something that's coming for the healthcare in the US as well. And
well, and two, just to, like completely, could we go the other way? Could we, yes, I understand health information is obviously secure. And this is in, I'm the Tennessean, and this is in the news as we speak, of Vanderbilt being, subpoenaed from our Attorney General for health records. So obviously our health information is private and needs to be secure. But at the same time, do we really need our providers to have 7 accesses to get into one little piece of information. So we didn't ever have to punch in a code or say who we were when we called a doctor on the telephone. We didn't have to proclaim who we were going to talk about before they called us back. And through we could dial the fax number, and God knows where we sent that result. But now it's very difficult to access different systems outside an enterprise. So, and you and I have talked about that before. To me, if somehow I had my own, just instead of my own credit history or my, you could see my credit score, you could see what I owed everywhere. I just wish I had one name, and there are already national identifiers for nursing. They're the national provider indicators. So how could we, if we could tie that somehow to my single identity within all systems, I think that would be phenomenal. Then my doctor would know what her password was. Maybe.
No, that's a very cool idea. I wanted to change the topic a little bit and
Sure.
ask about things that you do when you are not acting as VP of Clinical Informatics or as a university professor. What do you do when you're not working?
I became a grandmother this year.
Congratulations.
Thank you. And so baby Deacon was born March 3rd. And so they're in Oklahoma. So this is July 11th. I've gotten to see him 3 times already. I'm involved. So, and we have a child. We have 3 children. I live on a farm. We have about 50 cows. I don't know how many folks you interview. So yeah,
That's a lot.
So my husband farms, and so we're all my whole family is very involved in agriculture. We have a son in Baton Rouge, and then the new daddy and his wife are in Oklahoma, and then our daughter is in Iowa. So my life is very much around them, and when we get to visit. And I'm also involved, I mentioned I'm on the board of Uplands, is a continuing care retirement community. I care deeply about them and their mission and their continuity of care, that season of life. I think there's beauty in the sunrise and the sunset of life. And so I'm very dedicated to those people. And also I am involved in a women's philanthropic education organization. And I don't exercise enough. I like to walk. I listen to a lot of audiobooks. I try to get to yoga at least once a week. I don't make it very often. That's about it.
No, thank you for painting like a true human picture, because otherwise it's like very flat. This is like,
yes,
still informatics is all I'm about. And it looks like there is a lot more to that. You mentioned audiobooks. So what is the audiobook that you're listening to right now?
Right now, I can't highly recommend it. It's a little boring. I lost my mother to breast cancer 13 years ago, and I have always remember her speaking of this book that she remembered from the 8th grade that I have to ask my aunt what the teacher's name was. I can't remember. He read it to them, and it was Lorna Doone. And so it was just one of those someday. So I'm listening to that today. I just finished Bookwoman of Kentucky or something like that. It was like one from the WPA. She was one of the early librarians in Appalachia. And next I want on my wait list is, because Will told me about it last night, is the President and it's the Abraham Lincoln and Frederick Douglass book.
Is it about their debate?
No, not Frederick Douglass, the abolitionist.
Oh, okay.
Hold on, I'll say what it is. The President and the Freedom Fighter.
Very cool. Thank you for sharing. And I wanted to ask about, like, you've been through a lot, you've accomplished a lot in your career. What advice would you give to others who are just getting started in clinical informatics in 2023?
Find a mentor. volunteer for things. Almost everything that's made a watershed moment or a turning point in my career, I asked for. Even my Uplands experience is Dr. May Wharton was their founder, and I asked to portray her. I wanted to do, like a 20-minute one lady show, I guess. Could I do that for them? And then from that, I've been doing that for 12 or 14 years. I do it like once or twice a year. Into informatics, into this role, I asked 2 different groups for me to participate in the nursing informatics board certification courses, and one turned me down. Well, they both turned me down actually at first. And then I just kept knocking on that door. So, the day's probably never going to come that you're completely qualified for the job, or that your skill set exactly meets what they're looking for. But hone those skills through a mentor, volunteer, and keep learning.
Thank you. This is inspiring. Thank you so much, Debra, for your time.
Debra, thank you for sharing your wisdom and experience in clinical informatics and healthcare technology. Your dedication to building trusting relationships and driving performance improvement is truly commendable. This episode of the Health Tech Crew podcast was brought to you by Kepler Team. We specialized in building top-tier healthcare solutions for innovators focusing on HIPAA-compliant products. Fast-growing healthcare companies rely on us to deliver excellence. Join us next time as we continue to explore the technology and innovation in healthcare. See you in the next episode.